recording this computer. So this is Dr. Halasa. I'm the founder of Chronic Disease Prevention and Management, and we have today a lecture on the pathophysiology and management of the central pain. And then maybe next Monday we will do the drug addiction, part 2, because they're all linked together. Again, this event is CME, credited from the American Medical Association. I don't have anything to disclose, and we can start. Okay, so let's start with, can you see the screen? Everything is good? Everything is good. Can you see me? Can you see the screen? Yeah?
Yeah.
Okay,
yeah,
good.
that's such a nice photo.
Okay, beautiful. Okay, so again, this is CME from American Medical Association, Category 1. And I did send a link for you to get your CME. Again, it's very important to know the difference between central pain and peripheral pain, especially for patients or doctors who are doing pain management, because we are very good in managing peripheral pain, doing all these injections, and we thought that's it, right? But the reality is that if you don't cover the central pain, then you're not completely managing the patient with pain. And so most of the fellowship training that we have is in pain management. It's all about the skills and training to manage peripheral pain. We don't have much of training in central pain. And part of it because of lack of understanding the pathophysiology. And once we understand the pathophysiology, I think as a team of chronic disease prevention management, we can do better in managing both peripheral and central pain. And so when let's say if somebody has fracture, and of course that will start with peripheral pain because you will have peripheral injury that irritate the nerve endings of those peripheral nociceptive neurons. But once the fracture is healed out and the injury is neutralized and the fracture is healed, then we think that the pain will go away. Yes, most of the cases, pain will go away and everything is fine. But some cases, the pain will continue, although there is no fracture, the bone is healed and everything, but the patient still have pain. And that is the central pain. And we're going to understand how the peripheral pain or chronic peripheral pain led to generation of central pain. And then also after we understand the mechanism and the pathophysiology of central pain, then we can understand how to manage it and restore the neuroplasticity back to normal, which is the neuroplasticity of the central nociceptive neurons. And we're going to learn about the whole mechanism and pathophysiology in detail with animation. Of course, because I'm lecturing, it's hard for me to add people. So people who is being co-hosted, please help me up with that. So what's the difference between central pain and peripheral pain? Let's understand that there is central pain generators that would lead to peripheral pain. And then if this peripheral pain continue, it may lead to central pain to some percentage of people. Let's say 10 to 20%, they will continue having central pain. 80% will completely resolve as the injury that irritate or cause the pain is neutralized. So central pain, by definition, is central pain generator refers to neuropathic pain, which is central neuropathic pain that is occurred due to abnormal processing of pain signaling within the central nervous system. So when you have continued bombarding of the central nociceptive neurons, what will happen to this central nociceptive neurons? They will hypertrophy. What will happen is that they end up having something is called progressive neuroplastic changes, where you will see there is a growth in the dendrites of the central nociceptive neurons, and growth of dendrites and forming new connections of synapses. It's like a growing of a tree, branches of the tree from the the head of the neurons, that those dendrites will connect with the axons of the central nociceptive neurons, and they will form many synapses, and they become bigger in size because of that. So it's hypertrophy of the central neurons, central nociceptive neurons. And because of too much of synapses that's happening, then what will happen to the threshold of the pain? It decreases, and that leads to increased sensitivity to pain. And sometimes they end up firing automatically, even without any external stimulus, because they will end up inflamed, hypertrophied, and inflamed as well, and you have neurogliosis, and this will lead to spontaneous firing of the central neurons automatically without any external stimulations. And that explains the phantom pain, and that explains the central pain. And we see that in our clinics when we did everything to neutralize the source of the peripheral pain, whether it is this that's pinching those roots of the sensory neurons in the spinal cord, or or it is it could be because of the burn or fracture. If all of this being neutralized and the patient still have pain, then the pain is generating from inside the spinal cord and also from the brain itself, which is a piece of the brain is called amygdala, where they become hypertrophied and they generate signal of pain automatically, because of the neurogliosis and inflammation. And we're going to study the whole mechanism of function in the form of animation. So this neuroplastic changes that happen in an abnormal processing of the pain signaling is the reason why we have central pain. So central pain, it results from dysfunction in the central nervous system, and it could be inside the spinal or supraspinal. Supraspinal, exactly where? It's in the amygdala. So the generator can be located either in the spinal cord, yes, or in the higher brain centers, which is the amygdala. And we're going to learn that by animations, how all this dendrites is being formed, and how this central nociceptive neurons is hypertrophying, means the dendrites is growing like a tree, connecting with the axons, forming synapses and lowering the threshold, and even automatically generating pain signals from within the spinal cord or from the amygdala. And that's what we're going to see in the coming slides. And we call this also central sensitization, which is amplification of pain signal within the central nervous system because of this progressive neuroplasticity that's happening, this growth of dendrites and forming the synapses, and more synapses, more connections, and lowering the threshold of the synapses. And even it happened that they will fire spontaneously without any external stimulation. So within the spinal cord or the supraspinal, which is the amygdala. Or some, as we learn, if somebody has gangrene for a long period of time and peripheral pain evolved into central pain, and then what will happen? The surgeon decides to cut his limb. The patient still suffering from pain as it's coming from that area, from the amputation. And he will refer the pain as he has a foot still, although the foot is completely amputated. And that is because the firing of this pain signals, it's not coming from the injury because there's no limb. It is because it's firing that's coming within the spinal cord, and within the amygdala, which is the supraspinal part of the brain. And that we call also a phantom pain. I think everybody is familiar about it. So the peripheral pain generator, which is different from the central. The peripheral pain generator refers to nociceptive pain caused by inflammation or injury outside the central nervous system. So a burn in the foot, or gangrene, or fracture, or a stick, or a needle, or fire, whatever. All those injuries can lead to peripheral pain. Start with peripheral pain. And yes, if you have chronic peripheral pain and chronic stimulation of the central nociceptive neurons, then this may evolve into both peripheral and central pain. And then when you start to the injury is being neutralized because of the healing of the bone or the ulcer, and the patient still have pain, then you think about this pain is generated centrally and it's firing automatically because of the inflammation that's happening in the nociceptive or the pain pathway in the central nervous system. And we're going to learn that with animation, all the mechanisms there. Or it could be because of injury in the brain itself or spinal cord. That will lead to also central pain. So nociceptive, it arises from activation of peripheral nociceptors. This is the peripheral nociceptive or the peripheral nociceptive pain or peripheral neuropathic pain. It's because of the irritation that's happening at the end of the neurons at the receptors. We call them the nociceptors. An example of that. Osteoarthritis, somebody has osteoarthritis. Yeah, the pain is generated because of inflammation of the joints, which irritate the peripheral nociceptive neurons, right? And that will carry the pain signals to the brain, and then you feel that there's pain in your joint, right? But if the osteoarthritis is being healed by giving all this medication and the patient still pain, so the pain, we think that's not really necessarily coming from the joint, but maybe the patient has some central pain and we need to manage that effectively. Or somebody has rheumatoid arthritis. And most of the time, patient with rheumatoid arthritis, they would have both central pain and peripheral pain because of the chronicity of the pain. Burn and fracture is a good example, where in burn, when the burn is being healed, 80%, there will be no central pain and you feel okay after that, right? But 10%, they may end up having continued pain, even if the burn is completely healed. So we know that this is coming from the central, from firing spontaneously inside the inflamed neuropathic or the central, as we call central neuropathy or the central nociceptive neurons. They are inflamed and hypertrophied, and they are firing stimulus. I mean, without even external stimulus, they're just firing up pain signals, like seizure. Exactly. That's why we give them gabapentin, right? One of the medication for central pain is gabapentin because it's like seizure. It's just firing pain signals without any external stimulus. So that's a central pain. The clinical implication, peripheral inputs, blocking. So yeah, so if you have peripheral pain only and you block that nerve, right, the pain goes away supposedly. But if the pain continues, then this is not just peripheral pain. There's also components of the central pain, and we need to manage that effectively. But after understanding the pathophysiology of the central pain, which is tonight, we're going to learn about that. So we call this central pain syndrome. That's the name of it. It's a chronic neurological condition that affects how you perceive pain, and it can occur due to damage to the brain or spinal cord itself, or it goes by chronic peripheral pain that evolves into central pain because of bombarding, continued bombarding the central nociceptive neurons. What would happen? The central nociceptive neurons, they will hypertrophy. The dendrites will increase in number, the synapses will increase in number, and that will lower the threshold. And they will also have some neurogliosis as well. We're going to understand the mechanism. And that inflammation can lead to firing of those pain, like seizures, within the spinal cord or within the amygdala. And you see that firing signals of pain within the brain and within the spinal cord without any external stimulus. And that is the central pain syndrome. Or you have injury in the spinal cord. That could be a source of the central pain, right? Damage, inflammation, and inflammation and free radicals will open up the calcium channels of the pain neurons and lead to spontaneous firing. And we're going to see that in animation. So there is an abnormal processing of the, when you have abnormal neuroplasticity, abnormal processing of those pain signals, firing spontaneous pain signals without external stimulus. This is abnormal, and this condition we call it central pain syndrome. One of the management for that is progesterone. It does help because it turns into a GABA-like structure, and it works like GABA. And the other drug that we're going to learn, and that's really why we are coming up with a new insight of central pain management, because Dr. Joseph, I want to thank him for coming up with nicotine receptor partially agonist, which is the cytosine derivative. The one that we have, it's FDA approved, it's called varenicline, and the varenicline can have a potential to manage central pain and drug addiction. And we're going to learn that in the coming slides. So that is actually why we have some new here, some new news that we can use nicotinic receptor partial agonist, especially if we do it in the form of intranasal spray. We may be able to help in managing central pain. So that's something, that's the new thing that we're going to add for this lecture. So when the central pain syndrome arises from injury or damage, the affected brain or nerve system malfunction and send constant pain signal, right? When you have progressive, chronic pain, and that chronic pain signaling led to hypertrophy, progressive neuroplastic changes in the central nociceptive neurons, where the dendrite is it's growing and forming new synapses, and more connections between those pain signals and lowering the threshold. That abnormal neuroplasticity is the reason why we have this syndrome. And we need to normalize this neuroplasticity because it's a progressive abnormal neuroplastic changes. Same like autism. Autism is form of abnormal neuroplasticity, right? But this is neuroplasticity in the pain pathway, the central ones, abnormal, progressive, and more connections, hypertrophy. You will see the patient with central pain and the MRI that the amygdala is big in size. Hypertrophy. Why? Because they form a lot of dendrites and new connections and new synapses, and that will lower the threshold. And sometimes they fire spontaneously. And then the amygdala, if it fires spontaneously, will also give it will give you what we call the post-traumatic syndrome, where it will revive the whole event that caused the pain. So we're going to learn that from also the animations of the coming slide. So the central pain arises from injury or damage that affect the brain or nervous cells malfunction and send constant pain signal. In case related to chronic pain, nerve cells become overly sensitive to pain signals, right? Even with touch, the patient will have pain. Why? Because those central neurons, they form new synapses, abnormal neuroplasticity, a lot of connection. Think about bush of trees, the branches increasing in number and they are more connected and forming more synapses. So any even touch, it will lead to a lot of pain. And that we need, how we manage it, we need to restore the central nociceptive neuroplasticity back to normal. We need to break down those abnormal synapses that's formed because of the continuous stimulation of the central nociceptive pathways. So, central pain syndrome is often challenging to treat. It's not easy to treat because in order to treat it permanently, it's not just numbing and blocking the receptors, interrupting the synapses. You really need to do it for a long period of time to physically unwire those neurons because they form abnormal connections and too much of synapses, and we need to break them up. And what maintain this abnormal connection is the neurogliosis and inflammation. And that inflammation, the redox potential, it's high enough to cause expression of the proteins and forming dendrites. So if we able to lower the inflammation and decrease the redox potential, maybe this will help to cause those synapses to normalize and shrink back to normal level of synapses, because that's too much of synapses when you have abnormally too much when you have central pain. So you need to rewire or break down all those wires, and that's happening abnormally because of the continuous stimulation of the central pain pathway. And so it's difficult to treat, but we have the plan for treating it. and we're gonna come and we're gonna learn how to do that in the coming slides. And yes, it involves opioids and GABA, and it involves CBD and progesterone and serotonin uptake inhibitors and tricyclic antidepressant and glycine and many NAC and alpha lipoic acid and methylene blue, all those things, and exosomes, right? And also, which is the new thing that we learned, that we can also use the nicotine receptor agonist, varenicline. That's the name. What's the FDA approved? They use it intranasally for what application that they approved is for stimulation of the vagus nerve for management dry eye. So anyway, so what is the symptom? Symptoms associated with central pain vary widely among individuals, right? The location depends on the affected part of the nervous system, right? If a patient has a knee injury or fracture, and then the fracture heals and continue having pain, then that's where the pain will be referred to. That is the area where you have the central pain and continue pain, even if there is no fracture anymore or burn, and there's no burn, healed and everything, and patients still have pain in that area of burn. That's central pain. And intensity typically constant. It may come or go for some people, but how you feel it is neuropathic pain. So you feel this burning, pain, pressing, right? And you will feel sometimes numbness. Um, some patient will have allodynia, and some patient will end up with complex regional pain syndrome. Very clear with all the manifestation of complex regional pain syndrome. We have also sympathetic overactivity, vasoconstriction, vasodilation, and you see the color, this changing in the color of the skin, blue and white, and what other things? Heat and cold and all that stuff because of the norepinephrines are that's being released. They are inflammatory, right? They stimulate NOx enzyme, they increase the free radicals, so they cause inflammation, vasodilation, but also it's causing vasoconstriction. That's why you see some area hot and red and other areas cold and white. It's because of the sympathetic overactivities. And we're going to learn that sympathetic overactivities and the pain fibers, they're all connected. So we're going to see that in the coming slide, especially when we go through the animation. So central pain syndrome, what's the cause of it? There are many causes. Could be because of injury within the central nervous system, like stroke. There's injury there. Spinal cord injury, right? Injury can lead to central pain, inflammation, and damage, and that leads to, as I said, abnormal progressive neuroplasticity in the central pain pathway, too much of connection, abnormal synapses, and spontaneously firing like seizures, exactly, but in the form of pain, not movement, pain. Multiple sclerosis, all of this can lead to central pain. Any inflammation, damage, injury in the brain or spinal cord can lead to central pain. But other causes of central pain is that patient has peripheral pain for some reason, fracture, burn, and because of the chronicity, it leads to building up or activation of the central nociceptive neurons and continue activation, stimulation for many months, possibly years. Then this will lead to progressive neuroplasticity of the central nociceptive neurons, and you will see abnormal neuroplasticity, abnormal connections, and that can lead to central pain as well. And so, yes, it's very difficult to manage central pain because you need to break down those abnormal connections, this abnormal neuroplasticity, this abnormal synapses. You need to resolve it back and normalize those connections. So this, let's say the normal connection, just hypothetically, between those fibers, so between the neurons and just hypothetically, it's supposed to be 10 synapses. That's normal. But if you have 20 synapses, and because of the growth of dendrites, then that's abnormal. That's too much. That will lead to lower the threshold, and then that leads to what we call the central pain, because then any touch or little pressure, you feel a lot of pain. And sometimes the pain will generate automatically, even without touch from outside, without any stimulus, because of the inflammation that accompanying with the activation or overactivation of the central nociceptive neurons. And so you need, in order to manage it, you need to break those synapses. So it's kind of, you are unwiring those connections back to the normal amount of wiring, normal neuroplasticity. And so we have a lot of ways of treating it by, yes, by blocking those synapses and continue blocking them, or by decreasing the inflammation, both way. And we have many ways of doing that, whether by giving them GABA or giving them opioids or giving the CBD, always helps. But the problem with giving those big pharma products, it may help to calm the pain, but it may interfere with the mitochondria, and that leads to generation of free radicals if you interfere with the mitochondria. And then those free radicals will lead to inflammation, and possibly that leads to more pain, and really you don't do much in managing the neuroplasticity. You may be numbing the nerve, giving you some relief of symptoms, but it's not really a solution to just to give narcotics. We really need to figure out the way to decrease the inflammation as well, because the inflammation and the free radicals and oxidative stress is the reason why those synapses are being formed. So you need to find a way to calm and put down the fire and inflammation for those dendrites to shrink back and restore the neuroplasticity back to normal. So giving antidepressant, like nortriptyline, giving GABA, giving opioid, yeah, they will help. But the problem with those drugs, if you're chronically taking them, it may interfere the mitochondria, causing oxidative stress. So we're returning back to the ground zero, right? So we need to figure out to give patients blocking those synapses at the same time decrease the inflammation and oxidative stress. You need to do both. It's not just enough to block the synapses or to block those pain signaling, but also you need to find a way that those drugs are not causing problem with the mitochondria. All the big pharma products, opioids, antidepressant, all those, it can interfere with the mitochondria, causing oxidative stress. So you're blocking those synapses, yes, those receptors, but with long term, you're causing oxidative stress and inflammation. It's not going to work effectively. So we need to find a way that we can block those synapses and those transmission and pain, and at the same time decrease inflammation. CBD will do it. CBD will block those synapses transmission, at the same time have antioxidant effect and decrease inflammation, oxidative stress. So that's I like CBD. The nicotinic receptor agonist, the one that we talked about, which is the cytosine derivatives, they can do the same thing. And we're going to learn that from the coming slides. What other things? Light therapy can help as well, and B12 and NAC and glycine and things that's more naturally, where you can interrupt the pain signal at the same time. Progesterone will be good too. Progesterone does this. It helps. It works like a GABA, but at the same time, it increases expression of antioxidants. So the more natural product that helps to numb the pain, procaine is good too. Procaine is anti-inflammatory, antioxidant. For procaine, a lot of Germans, they use IV procaine, by the way, because it has antioxidants, plus it blocks and numb the area of pain. Ketamine is good, but the problem with ketamine too, it's long term. It can interfere with the mitochondria. So the more natural product is better. So you can start with big pharma just to put the pain down, and then start introducing all this natural thing, exercise, swimming, things that light therapy, supplement exosomes, and that helps to wean patients from the big pharma. So all the time in our chronic disease prevention management, we use the big pharma, but we try to wean them and replace them with more natural substances. Still, Metlam Blue is considered, does not interfere with the mitochondria, although it's a big pharma product. But methylene blue is a good thing to continue with it. CBD, nicotine receptor agonist. I don't know if they cause any mitochondrial dysfunction, but it does have a lot of good quality. Plus, it may have some antioxidant as well. I will go with that as well. Um, so we will talk about drug abuse or substance use disorder and maybe next Monday. Today we're going to focus more on central pain management. So there will be part one and part two because when you go through the animation, it's require a lot of mental activities and concentration. And that's the reason I'm asking you to bring some copy because when you go through all the animations and how the pain signals process in the brain, you will see it require a lot of mental effort there. So substance use disorder is a mental health condition characterized by a problem of substance use. It exists in a spectrum ranging from mild to severe, which is the addiction. The substance use disorder involves overpowering craving of source substances, increased tolerance, and withdrawal symptoms upon cessation of the drug. That's the problem with opioids. I mean, yes, the opioids will be good for managing central pain because they will intercept or block or numb those central nociceptive neurons. But the problem with the opioid, it will lead to oxidative stress, and it will lead to opening up of the NMDA receptor, which is the glutamate receptor, leading to calcium influx, and that leads to oxidative stress. So the problem with opioid is that, yes, you are calming the pain by interrupting the pain signaling, by hyperpolarizing the neurons of the pain neurons, yes. So you're numbing it with opioids, the central neurons, those central nociceptive neurons. But at the same time, you are inducing inflammation by opening up the NMDA receptors, which leads to calcium influx, and calcium influx leads to activation of NOx enzymes generating free radicals, and also it leads to mitochondria to start releasing those free radicals, and this leads to neurogliosis inflammation and oxidative stress. And oxidative stress will cause the mu receptor to be blocked. Oh, and then you need more opioid because those receptors of opioid is not working anymore, become insensitive. And that will lead to addiction because opioid also increase the increase of dopamine. And if those mu receptors are being blocked, then those pain will go back again. So you need more opioid. And because it's being blocked, then you don't produce enough of dopamine that you used to. So you need more of opioid to produce dopamine. And that dopamine that's being released is both to give you some euphoria, but also the dopamine is part of the descending analgesic pathway. It gives you that pain relief. So dopamine, yes, it is part of euphoria, but also it's analgesic. And because of the oxidation of the receptor of opioid, then you need more opioid, and then they end up with that addiction. And all their thinking is about how to obtain that drug because that drug helps them to increase the dopamine. And we know for the fact that all of our action and our movement is directed by which is increasing dopamine. So, for example, while you're sitting here hearing boring information, hardcore information, because you enjoy it, right? And it causes your dopamine to go up. But if you compare between sitting here and hearing all this hardcore information and going and watching TV, I think for you as a doctor, because you're nerds, you enjoy listening to this information because your brain is full of this information. You don't have much information outside medicine. So the only thing that entertain you and increases dopamine is this information. So staying here, your dopamine is going to be higher than sitting in front of the TV. And that's the reason why you're here. So every movement that we do is all driven by dopamine, right? Eating chocolate versus salad. Well, chocolate causes increase of dopamine, salad does not. So we prefer chocolate unless you train the patient and you can, or the person cognitively, and showing all the bad side of the chocolate. Say chocolate has sugar and sugar can cause oxidative stress and inflammation, get you sick, having stroke, and all this information, negative information, will lower the dopamine of the chocolate by cognitively. We got learning now, and then with time you start preferring the salad because salad is healthy and all the good news, and that leads to increase the dopamine of salad versus chocolate. But that's acquired training. Instinctly, our instinct, we prefer chocolate because chocolate instantly leads to more dopamine. But we can learn ourselves and train ourselves to lower the dopamine for chocolate by showing all the side effects of it, all the bad side, and showing the good side of salad. And that's cognitively, we acquire that. And that will make us prefer the salad over chocolate. So every movement we do is driven by dopamine, or those happy molecules. I like happy molecules to include serotonin and oxytocin and dopamine because they're all helping and giving you that rewarding effect. So the substance abuse involved overpowering craving for substance because that substrates. First, it gives them the pain relief, and second, it gives them the dopamine. And dopamine is euphoria plus analgesic. But because of the tolerance, because of opioid, cause oxidative stress and blocking the mu receptors, then you need more of opioid to get into that level of dopamine you need and pain relief that you need. And if you don't take the opioids, then the patient will be so pain on pain because of the oxidative stress cause more neuroplasticity, by the way. Opioid chronically can lead to more progressive neuroplasticity, by the way. And then they will be on fire, more pain than before taking opioids if they withdraw from opioids. And because of the oxidative stress generated by the opioids. And so they will have all the symptoms of inflammation, of the craving, of the sympathetic goes up and sweating and all the physical symptoms. So various symptoms include alcohol, opioids, stimulants, tobacco, nicotine, mechanisms. They vary, maybe the manifestations. Some of them are psychologically dependent, some of them are physical. We're going to talk about later. And all of this can lead to addiction liability factor and activation of the reward centers. All the addictive substances strongly activate the brain reward center, which is the dopamine, right? And that produce pleasure. Plus, again, there's dopaminergic. It's part of the stimulate the descending analgesic pathway, and yes, it will help in relieving the pain as well. Uh, And so, additional notes factors include how the substance is taken, its effect on the brain, and its ability to induce tolerance and withdrawal. And we're going to study that more with animation in maybe next Monday, because now we're going to focus on mainly on central pain. Okay, so let's go ahead and so substance abuse, use and misuse. Right, there's some different substance use and misuse refer to occasional episodes, while substance use disorder, this involved chronic, habitual, or pattern use. This is more severe. Substance use is not causing that much of addiction and rewarding as substance use disorder, where the brain is being completely programmed to obtain that substance. And all his thoughts, because of the inflammation that's caused by the substance itself, led to neuroplasticity of the brain, and not just for the pain, but also for the whole action and movement side of obtaining that drug. Your brain is programmed for one thing is to get that drug. And that's why when I was practicing pain management, those patients, they don't care about nothing. They look like zombies. And only thing they care is how to get that substance. There is no hobbies, there is no interest because there is rigid neuroplasticity in the pain fibers and also in all the actions, all the motor activities. There's neuroplasticity there, which is all driven by the rewarding, right, and increasing the dopamine, is to obtain that drug. So their thoughts, their activities, it's all directed. They are like autistic. Autism, same thing. It's abnormal neuroplasticity, and they cannot break up and form new activities and new pleasure and new rewarding. No, the only thing their brain and the rewarding and the circuits is to serve and obtain that drug. So similar to see them, they are disconnected from the society, disconnected from their wife, from their job, from everybody. And their brain circuits is all about the drug because that drugs give them both. They give them the happy molecules and it will give them that pain relief. And so that is what we called the substance use disorder. But if it's still not there, not that enough of neuroplasticity of the motor and the pain enough to stereotype the whole activities of the day or taking drug, then we just say that it's just more or less of misuse, right? So it's not there, but they will get there if they continue misusing it. They may end up becoming substance use disorder. And so there's many different way of therapies, right? Whether you use pharmaceutical, right? CBD, you use oxytocin, you use mushroom, you use ketamine, and cognitive therapy, family therapies, uh, pushing the patients to develop new hobbies and new interests to break through this, to break this rigid neuroplasticity that's only thing it's about getting that drug. So it requires cognitive therapy along with pharmaceutical therapies in order to break that rigid neuroplasticity of the pain, because you need to give them medication for pain, and you need to give them something that helps to increase the dopamine, but not that much. So something like partially agonist, like what are those partial? Nicotine is one of them. Nicotine receptor agonist, which is the cytosine or the varenicline. That's one. Uh, there is many opioid receptor partially agonist, right? Naloxone or naltrexone. Those partially mu receptor that gives you some pain relief, but also at the same time it gives you that dopamine release, but not that too much. Just to keep them going and break from that harsh morphine or cocaine or oxytocin or all those big drugs that we talked about. And so we have to go through there's withdrawal detox. Yes, even detoxing the body using ETA and all this thing that we remove all those inflammatory generators and anti-inflammatory and antioxidant light therapy, ozone. All this may help. Um, and stopping those drug addiction, but you need to give them long acting morphine, for example, instead of short acting naltrexone. You need to give them maybe nicotine receptor and partially agonist, things like that. The buprenorphine, methadone, naltrexone, um, and all of this may help along with cognitive therapy and um, swimming and exercising and all this good stuff. Naloxone is another one, a reverse opioid effect during overdose, yes. But naltrexone is for the chronic addiction. And long-term follow-up, right, is to prevent the relapse. So they have to go to rehab center and they provide them with all this therapies that we talked about. Okay, we're good? Okay, here we go. We're gonna learn about the whole pain signaling and processing in the brain so we can understand the way how we manage central pain. Without understanding the pathophysiology, you will not have a complete picture of why you're doing this, why you're choosing those drugs, why it's very important to reduce the inflammation, why it's very important not to upset the mitochondria. Because if you upset the mitochondria with your drugs, you will end up with oxidative stress, and oxidative stress will lead to blockage of those mu receptors, right? Then you end up with addiction again or a drug addiction. And you want to stop that from happening. Otherwise, you will end up increasing the progressive neuroplasticity, and the patient gets even worse with the treatment that you're doing, especially with those pain management doctors. If they're just giving opioids, they making the patient more worse because opioid, yes, it numbs the synapses, it numbs those central neurons. It may help in the beginning, but if chronically they're using it, it leads to oxidative stress and it leads to more progressive neuroplasticity of the brain. And it leads to drug addiction, and they need more and more of opioids, and they end up with suicide or killing themselves and doing a lot of crimes because their brain they cannot work. Their brain is only engaged in because of neuroplasticity only to obtain a drug. That's the only thing that gives them the pleasure. Sex is not giving them pleasure. Playing, hobbies are not. Work is not. Their brain is wired for obtaining that drug because that's the only thing that increases the dopamine for them, and that's the only thing that will cause the pain relief. And that we need to stop it, and we need to change the way we practice pain management. And I think we're going to learn how to do that by considering when you're trying to block those pain or numb those neurons, you need to do it in a way you also decrease inflammation and oxidative stress, because that is the reason why you have this progressive neuroplasticity. And that will break down this neuroplasticity back to normal neuroplasticity, and shrink those dendrites and break those extra abnormal synapses. So let's go ahead and understand how those synapses, how those abnormal synapses, how this progressive neuroplasticity happen in those central neurons. That is exactly what we're going to learn today from understanding the whole process of the pain. So let's say, for example, you put little torch of fire from a candle, right? It's a small one, not a big one, in your finger. So you will feel some pain. Signal goes through the peripheral neurons, right? This is peripheral neurons, goes here, and then all the way goes to the thalamus. Did you see that? Let's go back. Here. See that? The third thing starts from here. Okay, see this signal here? Okay, where it goes up to the spinal thalamic tract, ends up in thalamus. So when that pain signal reaches to the thalamus, of course, it's being sent from the peripheral neurons, peripheral C fibers, right? And it goes up to the spinal thalamic tract, which is the central nociceptive neurons, to the thalamus. When it reaches the thalamus, that's where you feel the pain. Feel it, but do you know where the pain comes from? No. In thalamus, when the pain signal reaches the thalamus, it just you said, "Oh, I have pain. I feel pain." But if you ask the patient, "Where's the pain?" they don't know. If they ask the patient, "What caused the pain?" I don't know. I just feel pain, but I don't know what caused the pain. I don't know the quality of it. I don't know how severe of it, but I have pain. But I cannot quantitate it. I cannot picture it. I cannot imagine where it comes from. So those questions that we ask about the pain, severity, quality, the nature of the pain, whether it's burning, stabbing, all that stuff, right? No, in thalamus, when signal reach there, you just feel the pain. Okay, so when we start understanding this pain signaling better in terms of severity, when this pain signal reaches the amygdala, then that's where I can know I can answer the pain from 1 to 10, how much. So the 30 of the pain is the job of the amygdala. Thalamus, once the pain signal reaches thalamus, gives, oh, I feel the pain. But you need the signal to go to the amygdala so the patient can answer from 1 to 10 how much you're paying. If the amygdala is not working, and there is some patients where the amygdala is not working, whatever pain inflicted on them, they don't feel it. If you burn the amygdala, those patients, they feel the pain, but they don't have, it's not severe for them. Or it's just a pain, but it's not a big deal. In order to feel the severity of the pain from 1 to 10, it has to go to the amygdala. Okay? So here, that yellow one, that's the amygdala. That's where we can feel the severity of the pain, right? And so that's called pain modulation, severity and processing. All of this is happening in the amygdala. Okay, and then what will happen to that pain signal? It went to the hypothalamus. Do you see that hypothalamus there? This one from amygdala to the hypothalamus. Now, hypothalamus will give you that response to pain. What is the response to pain? When somebody has pain, right, it's severe pain, let's say, or after the amygdala field, it's okay, it's severe, it's a burn of a fire. So that is where you start responding with your. What does the hypothalamus respond will be manifested? Sweating, holding your breath. You can see the face is the expression of the pain. They're squeezing their eyes and holding their breath because right, that's all sympathetic overactivities. That is the manifestation of pain. Maybe you could they a little bit make sound of cry, I like this, right? That is anything that's subconscious. That is the response of the hypothalamus. If it's severe enough, they will cry, right? Um, Crying, yes. All of this is anything that's subconscious. Yeah, that is the response. Who will produce that because of the overactivity symptom is the hypothalamus. Okay. But in order to know where is the pain, because that's one of the questions, right? When you take history, where is the pain? That signal has to go to the primary cortex. So let's go ahead and see here. See, the thalamus now is giving a signal to the primary sensory cortex. And that's where that's the patient. Where's the pain? Oh, my pain here is in my finger. But it has to go to the primary sensory cortex in order to feel where's the pain. Okay, and then what else? And then in order so that's the pain location. See that one? Pain localization. You need to get it there. So if you don't have that function, right, you cannot localize the pain. Do you remember when you do the testing, when you give them the prick testing and the patient has stroke that area, they cannot feel where it is. They may feel the pain, but they don't feel where is the pain. If you ask them where's the pain, they don't know where's the pain. It makes sense? Um, but if the stroke involved the thalamus itself, then they don't even feel the pain at all in the beginning. So that means that they don't the stroke involved the thalamus, not the sensory cortex. Okay, now in order to understand, okay, this pain is it needle pain? It's burn from the needle or from the crash? What exactly the quality of the pain, or in other words, the pain quality that require the secondary association area, this one. So the primary is up here, right? That gives you the location, and this one gives you what? It gives you the quality. Okay, this pain is kind of a needle prick pain, or this pain is coming from pressure, or this pain is coming from fracture of my bone. So all of that can be interpreted by the sensory association cortex, which connect with the memory, of course, from the past memory and all that stuff, and they start processing the information. Okay, and then where the pain goes in now, all of this information needs to be stored, right? All this information, all this experience of pain, and even the event associated with pain, all of this experience needs to be stored. And where it's going to be stored, it's going to be stored in the cortex. So let's see, and um, so let's go back again, and then so that's the sensor here. We got it. Then it goes where? To the memory. This is the hippocampus. So hippocampus will record all this event, including the feeling of the pain, the quality, the severity, and the event that leads to the pain, right? All of this will be stored in the hippocampus here. Okay, now, is this pain, is it severe enough that the patient can really control it and not necessarily cry and scream? If it's little pain, really, most of the time we don't need to express it out and cry and scream, right? But if it's too much of pain, then yes, that we have no control. We start screaming and yelling and crying. And it varies from one person to another, women and male. Most of the time, males, some women here will say, well, you didn't try delivery of babies. Yes, that's true, because you have the sex hormone, which helps you to control pain. But normally, without that function, men do tolerate pain more than women, outside pregnancy and delivery, of course. Um, and people in Africa tolerate pain more than America here. That's for sure. I mean, it has to do a lot with the way that they culture and all that stuff. Um, so it varies from one person to another. But if the pain is not that much, right? I'm not gonna cry if it's a little stick of pen or a little burn from a candle. I will not be screaming. So that pain will be assessed and it will be evaluated based on the memory, and they will send signal. The memory will send signal to the amygdala, and it all depends on how severe the pain is. But also, this pain will be sent to the prefrontal cortex. That's a cognitive. That's where we start thinking, oh, is this pain, is it strong enough based on our experience and memories? I mean, if it's trivial pain, your frontal cortex will have control over the expression of the pain, the subconscious expression of the pain, to the point the patient will not cry and scream. So see here that this is what's happening. The pain signal here will be sent from the memory here to the amygdala, and then from the memory, from the hippocampus, to the prefrontal cortex. If it's little pain signal, right? The prefrontal cortex saying, now, come on, this is a little pain. Just go ahead and just send an inhibitory signal and suppress the whole thing and suppress the feeling of the pain. So you can control the pain. You can even stop the feeling of the pain itself by cognitively, by sending inhibitory signals as you see it here. And that will go ahead and send inhibitory signals, say, hey, calm down, amygdala, and put the fire down on the amygdala. But that if the pain is trivial, right? You can control it. But if the pain is so severe, your cognitive and your control will not, and you cannot control the behavior of this pain. So you will cry and scream because the signal is very powerful that's coming out, coming to the prefrontal. To the prefrontal cannot really, your cognitive conscious cannot suppress it anymore. And the signal from amygdala will be sent to hypothalamus, and you see the sympathetic override, the sweating and screaming and yelling, and all the expression of pain will come out without being we cannot control that, right? You cannot control your cry and all that and screaming because the pain is so powerful that your conscious control, your prefrontal cannot do much there. So we can control pain by cognitive. And that's why, cognitive therapy is part of pain management because the cognitive can inhibit and suppress the pain. The feeling and perception of pain can be suppressed by the prefrontal cortex. They can send inhibitory signals. That's why when you do pain management, we do all this cognitive therapy. We say to the patient, hey, yes, you have pain, but you can control it. And you can start doing some other activities to forget about this pain. So through prefrontal by cognitive therapy, which is training the prefrontal cortex and providing instructions of changing your behavior and activities and start doing other things, and that may help. And recognizing, oh, you can control the pain and it's okay, and it's just pain from inside and nothing is outside, something like that. It does help to put the pain down. So cognitively, we can control the pain and lower the threshold of the pain by inhibition signals goes there. Okay, it makes sense. But what would happen if you end up, putting your hand accidentally into the stove? It happened many times, right? And you've had a big burn in your hand, big one, like in, let's say third degree of pain, the third degree, and a big area of your hand is being burned. Oh, that kind of burn, that kind of fire will send a massive amount of signaling, right? And it goes up to the same process, goes all the way up to the thalamus where you feel the pain, and then to the amygdala where you feel the severity of the pain, and then to the hypothalamus where you start responding by pain by crying, increasing sympathetic, and the sweating, and the vasovagal maneuver. That's all hypothalamus, right? That's a massive one that your cognitive cannot do much there of inhibition. Okay, and yes, you will localize the pain when it goes to the primary sensory area, You will know the quality of the quality of the pain. What kind of pain is it? Well, this is a burning fire pain, or it's a stabbing or a fracture. All of that will be recognized if you have a functional secondary sensory or secondary or sensory association cortex there. And then with interaction with the memory and with the past experience, all of this will start, processing those information. And based on the experience of the past, this is big, this is huge. I mean, this is fire, this is like burn, this is my hand is whole burn. It's a big thing. So you remember we start throwing all this big information and to increase the pain, by the way, the experience itself of past experience, it will add more to the pain, and you will feel more pain if you have past experience of pain, by the way, because that will add more fire there. And so it will add more pain, and amygdala will process all this information. Yes, it takes it from the memory, and then yes, it's too much. Then what would happen? Even if you send, and the memory will send signal, which is the hippocampus, will send signal to prefrontal cortex, and inform the prefrontal cortex. This is a big pain, huge pain, and your prefrontal recognize it, and you try very hard. You don't want to be embarrassed in front of your people, to cry and and scream and yell. So your prefrontal cortex, especially men, we try not to show weakness, and we don't cry, and we try to hold ourselves. So you prefer we'll try our best not suppress the hypothalamus, manifesting crying and yelling and screaming and sweating, all that stuff. But if the pain is so severe, right, this cognitive inhibitor signals was not going to be enough, and we let it go. So we cry and we scream and all that stuff. And that's what's happening when the pain is so severe. Okay, so if you see here that the amygdala is sending an inhibitor signal to prefrontal cortex and say, "Hey, man, shut up! You cannot. This is massive pain. Let's just let go and cry and have Zava maneuver because all this process helps in relieving the pain." So yes, your cognitive will try to inhibit, but the pain is so severe to the point that it will inhibit signals from the cognitive, and it's just hard for you to control your uh, behavior of pain, crying and yelling and screaming, and it just comes out without your control anymore, um, because it is severe. And what else? The other thing is that yes, it will send signals to hypothalamus, which give you all the manifestation of the subconscious of the pain response, increasing somebody and all that stuff. But also, what's the good thing about hypothalamus, right? Yes, if you cannot control cognitively your manifestation of pain, subconscious manifestation of pain, your subconscious manifestations of pain, which is hypothalamus, it will help you, if it's functional, to start activating descending analgesic pathway. And that's very important to put the brake on the pain. And that's what's happening. You see, the hypothalamus here has been sending signals to the quadriductal and locus sternus, and rostral ventrolateral medulla. All of this is descending analgesic pathway. And if you see it here, this is what all those neurons are. Those neurons are serotogenic. Those neurons are norepinephrine as well, and all of the serotogenic and norepinephrine and dopaminergic, they stimulate these GABA neurons or encaphalinic neurons, right? And this will cause release of GABA here and inhibit and put a brake on the pain signals that's coming from here. So yes, the descending analgesic pathway will be active here. Valsalva maneuver will help to stimulate this descending analgesic pathway, by the way, right? Because it will stimulate the hypothalamus that sends signals to the descending analgesic pathway. So when you do it at Valsalva maneuver, you're increasing the activity of the brake of this, and those are serotogenic, norepinephrine. That's why we take serotonin reuptake inhibitor, because it will increase the release of serotonin here, norepinephrine here, dopamine here, and all of this will stimulate the GABA and also the encaphalin neurons, interneurons, which will inhibit the pain signals that's coming from the peripheral neurons, those receptive neurons. It will inhibit those pain signals from coming in and stimulating, right? So that's very important. part. So when we use dopamine when we use dopaminergic or serotonergic and norepinephrine, all of this would help in relieving the pain. In addition, we use CBD as well. There is CBD neurons here, in addition to the encapsulogenic, and they are in it. So that's how the CBD works, by inhibiting the income new pain signals by basically activation of the descending analgesic pathway. And we're going to see that in the coming slides. Okay, so what also happened here? I see that how it's inhibiting this nociceptive neurons. Okay, so what happened here? Let's go ahead and say the pain is continue even after the torch is being, because there's a burn, right? So the pain will continue even if you've removed the torch of fire. It's going to be massive pain, and that massive pain, we will see how this chronic pain of the burn leads to hypertrophy of the central nociceptive neurons. We're going to see that right now in this animation. And we will see how the central nociceptive neurons, the dendrites is increasing in number, the synapse is increasing in number. So you have hypertrophy in the central nociceptive neurons at the spinal cord, and that is the cause of anesthesia, secondary and primary anesthesia and allodynia. And also, it is the reason why we have this central pain, which can be fired spontaneously, even without any external stimulus. So let's go ahead and understand how at the spinal cord level, and what's happening at spinal cord level of growth of the nociceptive neurons. And the growth of nociceptive neurons, we're talking about dendrites, right? Like branch of trees. The branches of trees is increasing in numbers, and connection with axons is increasing in numbers. That is happening the same time it's happening in the amygdala, by the way. So let's go ahead and see the process of the progressive neuroplasticity, increasing the number of dendrites, the hypertrophy of the central neurons, and the mechanism of anesthesia of primary and secondary anesthesia and allodynia. We're going to see it right now. Okay, so let's say, for example, here the C fibers from the peripheral neurons. We saw this is the peripheral neuron. This is the central neurons, and we're going to see that the central neurons is growing and increasing the number of the dendrites, and that's a growth, right? Hypertrophy growth, or we call progressive neuroplastic changes. So what will happen when this peripheral signaling from the burn is continually bombarding the central nociceptive neurons? The peripheral nociceptive neurons is continually bombarding the peripheral nociceptive neurons continue bombarding the central nociceptive neurons, causing hypertrophy, causing progressive neuroplasticity, causing increasing number of dendrites of the central neurons. We're going to see that. And we're going to see the mechanism of analgesia, the primary, secondary analgesia, and hypergesia, sorry, primary and secondary hyperalgesia, along with the mechanism of allodynia, and along with phantom pain and spontaneous pain that's happening, especially it happened when complex regional pain syndrome. So let's go ahead and see that, right? All right. So when you have this pain fibers is being stimulated the peripheral neurons here, it will release the glutamate, and the glutamate will open up those calcium channels here, and the calcium channels will go. The calcium will go in, which is the yellow one here. Let me go ahead and go back again and show it to you. Okay. So here the signal. See that pain signal here. See the release of the glutamate, and the glutamate is attaching to the NMDA receptor, which is glutamate receptors. And what they will do, those white dots here, those are the glutamate. They will open up the calcium channel, causing influx of calcium. This yellow ones here, and causing the influx of calcium. The calcium will activate the MOX enzyme, which is the gray one here, or you can consider those mitochondria, and causing the mitochondria to release a volcano of free radicals. So you have increase of oxidative stress here, oxidative stress that will lead to increased expression of the proteins. The proteins that I'm going to make out of them new dendrites. So you're gonna see that. Okay, so here we go. Calcium dioxide activate the NOx enzyme or causing the mitochondria to release the free radicals, which are the red ones here. And then this goes oxidative stress that increase the expression of the genes to make proteins, to make what? To make dendrites. Let's see the dendrites, how it's gonna go and form. See this one here? Oops, that's a dendrite. It's being formed, right? That's a growth. That's hyperplasia. That's a neuroplastic changes that I don't want. So what will happen if you increase the dendrites and increase the number of cells? You used to have one here, and now you have two. The threshold of the pain will decrease. And then just a little pressure on the palm here will cause what we call the primary hypergeusia, just a little pressure. Normally, a little pressure like does not cause that pain, but because of the primary hypergeusia, just a little pressure here is causing a pain. That's because of the progressive neuroplasticity. That's because of this extra synapses that's formed, that's abnormal ones. You see that one? And that leads to the primary hypergeusia, right? So when you touch the area of the pain, normally when I press like this, we don't have pain, but or just you put little pressure there. Now we have pain when you put pressure or putting squeeze it or that. Usually we don't have that pain, right? That's primary hypergeusia. Okay. Okay. What about the secondary hypergeusia? Secondary hypergeusia, when you form a dendrites that's connected to the area that's not the area of the injury, outside the intact skin. So this one, anything here, this is called primary hypergeusia. If you have anything, if you stimulate anything outside the injury, then you have what secondary hypergeusia. So if I press this away from the injury, it's called secondary. Why? Because of the overactivities of the central nociceptive neurons, you will form a dendrites that will connect to the pain fibers, the peripheral nociceptive fibers that's coming from an area away from the area of the injury, like here. Normally, you don't have pain when you press here because it's away from the injury area. Okay, so let's go ahead and see that. Okay. Uh, okay, let's go ahead back here. This is, we're talking about the primary one, primary hypergeusia, right? Okay, now let's go ahead and see the secondary hypergeusia. This is the primary hypergeusia, see that? Okay, primary hypergeusia, put pressure there, right? Then, because of this dendrite that's formed and this new synapse, right? Just a little pressure here was causing pain. See that one? Okay, see that? So it's not just here, but also here. Yeah. It makes sense? So pain is coming from here and also from here, both. So you have some irritation here coming, and that leads to the lower the threshold, and that leads to the primary hypergeusia. Now let's go ahead and see the secondary hypergeusia. Secondary hypergeusia will form when you have another dendrite that's being connected to nociceptive neurons that's coming from here, from away from the injury area. That's secondary. See this? This is the dendrite. See this? Is expressing protein. See this here? I'm gonna make it those dendrites. Okay. 1, 2. Okay. Let me show you how it's gonna be made. Oops. See that one? Here. It's abnormal neoplastic change. That's abnormal. It's like a tree growing up branches. Hypertrophy here, right? Increasing the size of the central neurons, right? That's happening also in the amygdala here, by the way. Okay, so now I connect with the nociceptive neurons that is not from the side of the injury, right? Okay, so when I put pressure in here, we will feel the pain. That's secondary hypergeusia. See that? Okay, so let's say this is the area where it's supposed not to have pain. Okay, so this is secondary hypergeusia here, right? And oops. Okay, so here we go. Now you feel the pain as it's coming from here. Okay. And then, okay, see here? Okay. It makes sense? All right. So let's go ahead and see what will happen to develop allodynia. We're going to learn that. Well, an allodynia, the dendrites will be formed, and this allodynia will attach to touch fibers. See, this one is touch fiber, right? This one, A, B fiber, K, the sensation of touch. Okay. and normally they are not connected to the pain fibers, but because of the continuous stimulation of the central nociceptive neurons, they will form dendrites that will that will connect to the touch fibers. And then if you just little touch the hand, which is not the painful stimulation, you will end up with the pain. And then if you just touch the hand with a feather, with a feather, the patient will have a lot of pain. Why? Because the touch fibers is now connected to the pain fibers. You want to see that? Let's go ahead and see the animation here. See that one here? Oops, it's formed here. See that? Okay, so now when I put the feather there, see that? Okay, now you're getting stimulation from this neurons, getting signals here, right? And it gives you what the allodynia. This is the allodynia here, right? Oops, here. Touch fibers, touch sensory fibers is carrying pain signal, right? And you feel the pain just by touching. Okay, now because of this free radicals that's being generated from the mitochondria and enzyme, all those free radicals will be released out and they will irritate the neuroglia. See that neuroglia here? And that leads to neurogliosis, inflammation. And neurogliosis means inflammation, means more free radicals. So this neuroglia cells will start secreting more free radicals. And these free radicals, was being released, they will open up the calcium channels spontaneously and cause the central neuron to fire spontaneously without any external stimulus because of the inflammation that's happening from the oxidative stress, from the free radicals, right? So see, this neurogliosis is being formed, and that leads to release more free radicals, and those free radicals, if you see it here, they will open up the calcium channels, causing spontaneous pain. And what other things that neurogliosis is going to do? The neurogliosis will cause um, regressive neuroplastic changes in the descending analgesic pathway. So what we have here in the pain fibers, the central nociceptive neurons, you will have progressive neuroplastic changes. You will have growth of dendrites, and you will have neurogliosis around those central neurons, right? But those free radicals that are being generated from the inflammation, they will cause the opposite. They will cause regression. They will cause decrease in dendrites and activities of the descending analgesic pathway, and that's not good because you are messing up with the brake, with the descending. So you will have the regressive neuroplastic change, atrophy, decrease in dendrites because of the inflammation here caused by neurogliosis. This inflammation, yes, it stimulates the protein expression and forming dendrites in the central nociceptive neurons, but it's the opposite. Those neurons, they will sense the free radicals differently, the opposite. They will cause shutting down the protein expression and shutting down the formation of dendrites and shrinking in the dendrites, and this will cause problem in the brake. It's like somebody has driving a car and his brake tubes are leaking oil. You know, when you break the oil pump, the same thing here, and this causes a problem. This will lead to phantom pain. This will lead to central pain. And not just that, those neurons, they don't need any more signals from outside. They can fire spontaneously. You want to see that? We're going to see that. But after we see the regressive neuroplastic changes, see the number of dendrites here is going to shrink. Oops, used to be two of them. Now it's only one. It's like exactly when you are making when you cut the brake oil tubes of the car. So, same thing here. Regressive neuroplastic changes here. Progressive neuroplastic change in the nociceptive pathway, and regressive neuroplastic changes in the analgesic pathway. Okay, so what will happen to those free radicals that's being generated from this gliosis? They will cause opening up of the calcium channels, those glutamate receptors, and cause the neurons to fire spontaneously. See that fire? Spontaneous fire of pain. Wow. And then you have pain without any external stimulus. See that one here? Okay, that's good. So let's understand something is called complex regional pain syndrome, right? The central pain that we learned today, it can progress and become complex regional pain syndrome if you have too much of sympathetic overactivities, because they are connected. We're gonna see that right now with animation. So let's say you have pain signals coming up spontaneously because of the inflammation here and hypertrophy here and progressive neuroplastic changes. And those pain signals will go up, same thing to the thalamus and to the amygdala and then to the hypothalamus, if you see it here. And when it gets into the hypothalamus, we mentioned that it will stimulate the sympathetic and will stimulate sympathetic overactivity. And the sympathetic also will happen, they will have progressive neuroplasticity as well. And you have too much of sympathetic. And what will happen here when you have too much of sympathetic? See that sympathetic 5 activities here, this one here. Oops, here. This is the sympathetic ganglion. Oops, oh Lord, releasing norepinephrine. And you have too much of norepinephrine in the hands. So norepinephrine, what it does, norepinephrine stimulates NOx enzymes, which generates free radicals, causing inflammation. And inflammation causes vasodilation and heat. So you have area of heat and vasodilation. But also norepinephrine causes vasoconstriction, and that's why you will see cyanosis and pale in some area, right? And this is complex regional pain syndrome, right? So from central pain progress into complex regional pain syndrome because of the connection between the pain and the sympathetic pathways. You see that how? And then you have here the hand is discoloring, and this evolved into complex regional pain syndrome. Okay, let's go ahead. What will happen if you wiggle the leather in front of those patients with complex regional pain syndrome? Have you experienced that? They will cry and run away from you. Patients with complex regional pain syndrome, if they know they hate me because they don't want me to examine them at all, and they ask me, please don't examine me. So in the beginning, in order to prevent that, prevent them from being, because just hearing the sound of you're going to examine them, the pain will go up because of the memory they have. And the whole thing came from amygdala and the memory. The memory triggered the amygdala, and then they have the whole trauma of touching. Okay, so you make sure when you have a composition pain syndrome, say, I'm not going to examine you, I'm not going to touch you. They have to feel that thing first, because the pain will become so severe if they expect the doctor's gonna touch them. Okay, so don't show them any needles, and don't pick them with any needles, even in the area that's not in the area of the pain. Do you know that if you inject them even in the area, like let's say they have the pain in left arm, and you inject the needle in the right arm, the complex region pain syndrome will transfer into the right arm, and you will cause a lot of problem to the patients. So they don't want to be touched, and they don't do any injections for them, please, because you can make the pain well worse, and you can transfer this complex regional pain syndrome to that area of where you put the needle in, and you'll be responsible for that as well. So it is very critical that those patients are being treated right, and you have to have those experience and skills to treat to really treat those patients. So what I do for them, I how I treat them, I give them light therapy first, and shine the area of the pain with light therapy, and I will shine the area in the sympathetic ganglion. I will not do the sympathetic block in the beginning. After I will try to give them those light therapy. Plus, I will ask them to put the cream themselves. They can touch themselves, but you cannot touch them. Okay, so you give them the cream, and they can rub the cream in the area, and that cream contain alpha lipoic acid, nitroglycerin, and gabapentin, and light therapy, and then I may decide to go ahead and do some gangrene block, which is the surgical one, to block the sympathetic activities. But I will start with light therapy first and topical cream, and then when they feel comfortable, then I can go ahead and start doing the sympathetic block for that area of pain. And then there's many other things that you need to do: cognitive therapy, some CBD, and the naltrexone, uh, nicotine receptor partially agonist, which we talked about. We're going to talk about the coming stuff. Some serotonin reuptake inhibitors. Yes, you give them all this to help to calm the pain and also optimize their health. Give them 6 hormones, optimize that. Very important, the progesterone, and we're going to see that in the coming slides. So when if it happened that you want to experience allodynia, if you touch them, they will have severe pain from that. Touch. Suppose you touch, you don't have pain, right? And it goes all the way up to the same process that we talked about. But after it goes to the hypothalamus here, the hypothalamus will send signals to a nucleus. It's called what? Hibinola. Hibinola is a center of hate. This you have two centers in your brain, by the way. Center of hate and center of love. The tegmental nucleus is the center of love, and the hibinola is the center of hate. Why is that? Because when this pain signal reaches the hibinola, why the patients hate, fear, and move away from you, and sometimes leave the clinic completely? Because the hibinola will be activated, and the hibinola, when they are activated, they inhibit the tegmental area, or tegmental nucleus. And when they inhibit tegmental nucleus, this will inhibit or decrease the dopamine release to the nucleus accumbens. And when the dopamine is decreased in the nucleus accumbens, this will initiate the movement away from the stimulus, away from the feather that you're wiggling, away from the clinic, away from you and your face as a doctor. They will hate you. And so this is the nucleus that leads to moving away because it decreases the dopamine release from the tegmental area, which initiate the all motion movement of the patient away from you. So if you want to make the patient to move toward the stimulus, you activate the tegmental nucleus. This is the rewarding center, the interaction between tegmental nucleus and the nucleus accumbens. If the dopamine is released from here, this will initiate the movement toward the stimulus. If it's being inhibited, then all your movement is going to be moving away from the stimulus. So definitely this is pain stimulus, of course. It stimulates the hate center, the hibinola, which will inhibit the tegmental nucleus, which will decrease the dopamine release and the nucleus accumbens, which will cause initiation of the movement of the patient away from the feather, away from your face, and away from the clinic, and they run away. Okay, and the whole experience of this feather and the pain and all this is going to be stored in the hippocampus. Okay, so all this experience is going to be stored there, and they have the experience before of this. And so, anytime you wiggle a feather, they will experience the whole pain. This will trigger the whole pain. If they have problem before with the needle and cause the pain, all is going to be recorded, and all of this memory will trigger the whole pain. Even hearing the sound of the doctor, or hearing the sound of that you're going to examine them, or just it will trigger the whole pain. Okay, they're very sensitive now. Now, do you remember I said whatever happened here is happening here in the amygdala? Yes. And you will have a lot of dendrites, progressive neuroplastic changes, to the point the amygdala is inflamed and big, right, because of neurogliosis, and they can fire spontaneously. Any memory of the past, of the trauma, even memory, can initiate the pain, whatever caused the memory. And so, if anything that triggered the memory, let's say the fire, even sound of the fire or looking at the fire, it may trigger the whole pain. And that leads what we call the post-traumatic syndrome. And it starts from the memory, it triggers that, and along with the amygdala, and that leads to the whole post-traumatic syndrome. You want to see that post-traumatic syndrome? Okay, let's go ahead and see it. Okay. Again, let's go back again to the hibinola. In addition, the hibinola inhibit the tegmental nucleus and dopamine release in nucleus accumbens, and they inhibit the rewarding, definitely, and cause the patient to move away from the stimulus. That this inhibition, the hibinola also will cause inhibition of the descending analgesic pathway. That's not good, right? What will happen when you inhibit the descending analgesic? You are inhibiting the brake, and you're causing more pain, by the way. So anything that stimulates the hibinola is not good because the pain will increase. Why? Because your descending analgesic pathway will be inhibited by the habenula. If you see it here, do you see that one signal coming um, from the habenula here? Okay, see that? It's inhibiting the descending analgesic pathway. Okay, and so the pain will increase, and you start moving away from. So this is what I'm talking about. The whole experience is being recorded, and the habenula is being stimulated, and that is the if the patient experiences any memory, any sound of the event, or smell, or touch, anything that memorized them or trigger the memory of the event, it can cause the amygdala to fire spontaneously from the memory of it and cause what we call the post-traumatic syndrome, right? You want to see the post-traumatic syndrome here? Yes. So you start from amygdala all the way up and in the memory. This is uh, the post-traumatic syndrome from the brain, right? And most of the time being triggered by sound or hearing of the event or memory or flashback. Sometimes it happens automatically just because, um, the memory initiate the whole picture of the flashback of the event. And it can be triggered by any other stimulus, smell, sight, anything that trigger the memory can activate the amygdala. And amygdala can fire spontaneously, even without any memories as well. And you will end up with something. And if the amygdala is being fired spontaneously, then the whole memory will be vivid in front of the patient, like a flashback, and he will see the whole. He will experience and visualize everything, and this is called the post-traumatic syndrome, right? So the amygdala fires and stimulate the memories and simulate the pain. And can you control that? No, because as I said, the amygdala is sending a powerful inhibition signals to your prefrontal cortex where you cannot control it. Even the patients say you cannot control those flashback and memories and trauma. No, I can't. It just comes, and the memory and the pain event, and this is all because of this um, abnormal neuroplastic change that involve the memory, that involve the amygdala, that involve the neuroceptive events, that involve the whole memory of the experience. It can be it's recorded and it can be playback again and again. Um, and so the amygdala neuroplasticity is responsible for the post-traumatic syndrome. And so when you do the MRI, and there is also functional MRI, you can see the abnormal activities of the amygdala, and you can see the amygdala is bigger in size. Now, what we do, how we treat patients, how we can cause restoring the neuroplasticity of the nociceptive neurons and the memories, and fade the memories of the trauma, and you need to break those connections, those abnormal wiring of the sympathetic and the memory and the pain fibers. All of this needs to be broken, normalized back, and look for other activities that will create a new circuit, and reward it with dopamine, of course, that will disengage the patient from the traumatic memories, that will decrease the neuroplasticity of the pain, and this hypersensitivity, and all of that. So we give the patient opioids. Opioid does help because opioids does cause numbing and decrease the synaptic activities of the pain. And you can see that by giving opioid here, it will open up the potassium channel. When potassium channel is open, potassium is moving out, it will lead to hyperpolarization of the neurons, and this will decrease the activities, the nociceptive activities, and the pain signaling that goes to the brain, and it helps to put the fire down. But the problem with the opioids, that's the problem. Chronic use of opioid, maybe in acute condition, it's okay. Put the patient down, put the pain down. But the problem with opioid, it will open up the NMDA receptor, causing calcium influx, and then calcium will activate the NOx enzyme, and calcium will cause the mitochondria to fire out free radicals. That will lead to expression of the protein and more dendritics. That's the problem with opioid. It does help to numb the sympathetic, the synapses, and the pain signaling, but chronic use can lead to more progressive neuroplasticity. And that's what you don't want. Because if you stop the opioid, come on, the patient will be in tremendous amount of pain because you increase the sensitivity of pain because of the opioid. And you have tolerance. Another reason of the tolerance, those free radicals that's being generated, which are the red ones here, they will block the mu receptors. So those opioid that you're giving, the dose is not enough. You need to give them more because the mu receptors have been blocked. Let's go ahead and see the animation here. See the opioid here? See it's opening up potassium channel. See it's hyperpolarization analgesia. That's a good thing. It's a good part of it. What is the bad part? The bad part is opioid will cause inhibition of the activation of NMDA receptor and causing the calcium channel to go in. And that calcium will activate the NOx enzyme. NOx enzyme generates free radicals. That free radicals will cause desensitization of the mu receptors. These free radicals will cause further regressive neuroplasticity of the descending angiostic pathway. These free radicals that's being generated here will cause inflammation and neurogliosis and inflammation and more neuroplasticity. These free radicals will cause more expression of proteins that leads to more dendrites, more progressive neuroplasticity, and that's not good, right? That's not what you don't want. Okay, so what we need to do, can we open up potassium channels without opening up calcium channel, without opening up NMDA receptor, without causing oxidative stress? Yes. CBD can do that. There are CBD receptors here on those pain fibers. And when you give them CBD, it does help to increase the potassium channel, same like opioid does, numb the nerve, not as effective as opioid, very important to know. But it will cause blockage of the NMDA receptor, preventing the calcium influx. That's completely opposite of what opioid. So it does have an antioxidant effect. The CBD has hyperpolarization, yes, analgesia, but at the same time, it inhibits the NMDA receptor, it inhibits the calcium channel entry, it would inhibit the NOx enzyme activation and all the free radicals. So that's a good thing, right? Plus, CBD has it can have the COX enzyme, so it decreases inflammation, right, of the neurogliosis. That's a good thing about CBD, right? And if you do that and you decrease the inflammation and the oxidative stress, you open up the mu receptors, right? Because of the antioxidant neutralizing those free radicals, and you make those mu receptors more sensitive. And this may help to treat addiction when you give the CBD. Is that good? Make sense? Okay, what else you can do? You can give them tricyclic antidepressant. We know the descending angiostic pathway, those neurons, they release serotonins, they release norepinephrine. So tricyclic antidepressant will increase the norepinephrine. The norepinephrine serotonin will activate this GABA neurogenic or anticholinergic, right? And this will help to inhibit those pain fibers. You see that? The pain signals. So this is the interneuron GABA and caffeinic, and they are inhibitory, and they will hyperpolarize those neurons and intercept or inhibit those pain signals, putting brake here. Okay, so increasing the activities of the synergistic pathway by increasing the release of the serotonin and norepinephrine by tricyclic antidepressant serotonin reuptake inhibitor. That's a good one. What about GABA? GABA will go and inhibit the NMDA receptors, right? That's a good thing, preventing the calcium channel from entering. And that's a good thing. Ketamine can do that as well. And all of this will decrease oxidative stress and decrease the and help to regain the sensitivity to the opioids again or to your opioid of your brain, right? And eventually this will help to treat addiction. You can treat it with ketamine and GABA, and it does help to numb the neurons as well. What else? You give them non-steroid anti-inflammatory drugs, right? Well, that's good because this will help, especially the natural ones, like curcumin. That would be good. It decreases the inflammation. Yes, you need to give them something that helps to decrease the inflammation, like aspirin or steroids will also help in decreasing the inflammation. That's why we give epidural injections of steroids. And decreasing the inflammation, decreasing the free radicals will help to decrease the oxidative stress. And you decrease oxidative stress, you help to manage the or cause or normalize the neuroplasticity of the pain fibers. Because what causes the neuroplasticity is this high oxidative stress, is the inflammation. And all of this helps to decrease inflammation. When you decrease inflammation, those dendrites will regress, those ones for the nociceptive, and back to normal. Okay, B12 will work like ketamine. They will block the NMDA receptor, as you see it here. So let's go ahead with steroids. As you see, it's blocking the COX. Steroids, same thing here. Okay, what about B12? Blocks the NMDA receptor, calcium. That's a good thing. If you block that, you increase the antioxidants effect and neutralize those free radicals and restore the receptor activities. Curcumin will definitely help the stimulation of the antioxidant enzymes as well, and neutralizing the free radicals, but also to have the COX enzyme, decrease inflammation, neurogliosis. Alpha lipoic acid also, they neutralize the free radicals. Exosomes will be good too, right? Exosomes will help to increase the expression of those antioxidant enzymes that we carry the MRI, and it will definitely decrease the inflammation, decrease oxidative stress. Anything that increases inflammation and health optimization that we're doing, and sex hormones as well. What else that we have? We learned recently that nicotine receptor partially agonist may also help, right? Why? Because although I didn't put it here, but we got to learn it now, and I think this will be the last thing. When we finish that, we're done from this lecture because it's too long. If I give nicotine receptor agonist, which is the cytosine derivative, which is the cytosine that we talked about, right? Um, last week with Dr. Joseph James. And what we learned that the cytosine derivatives, which is coming from the alkaloid from nature, but the big pharma, they took it and they tweak it and they turn it into vernicillin. And this vernicillin or nicotine receptor partially agonist, what it does here, it will help to increase the dopamine. So that's a good thing. If you increase the dopamine and increase the enkephalin, you increase the activity of the descending energetic pathway. So that's good. But also, it helped to increase the glutamate transporters. You know, the glutamate transporters here, or glutamate transporters in the neuroglia. So that will help to clear and clean the glutamates. And when you clear the glutamates, right, you decrease the NMDA receptors activities and the calcium influx. And that's a good thing for managing neuroplasticity, right? Because you're decreasing inflammation. You're decreasing the influx of calcium. We know part of the activation of these neurons is by increasing the calcium influx, right? That's from the NMDA receptors. And we know this calcium also is causing the free radical oxidative stress and causing the expression of the dendrites. Can we inhibit it? Yes. If you increase the glutamate transporters and reuptake of glutamate, right? That's another way to decrease the activities of the glutamate activities, right? Um, the reality is that those glutamate is the reason why those are how those pain fibers works. They work by glutamate. Those white things here, you see those ones are glutamate, and they are the one who is opening up the calcium channels and leading to the firing and stimulation. So who's mediating the whole neurotransmitter is the glutamate. So anything that inhibits the glutamate is a good thing, right? You block the pain signaling because the glutamate is responsible for it's a pain neurotransmitters. And anything that clears the glutamate, like nicotine receptor agonist, partial agonist, which increase the transporters of the glutamate, then you're clearing it from the synapses, then you are inhibiting the pain fiber signal. It's not just opening the calcium and causing increased free radicals, but the pain signals is actually through the calcium channels. The activation is by glutamate. So anything that block the glutamate receptor, NMDA receptor, like ketamine and GABA, they inhibit the transmission of the pain by blocking the NMDA receptors, the glutamate receptors. All right. And when you block the calcium channel, in addition to that, you're decreasing the free radical generation and inflammation. So if I can increase the glutamate transporters and clearing the synapses from glutamate, it works like ketamine, those nicotine receptor agonists. So in addition to increasing the dopaminergic neurons and enkephalin, that leads to increasing activity of descending analgesic pathway. The nicotine receptor pathway agonist also helps to clear up the glutamate by increasing the expression of the transporters of glutamate. What are the things that we have? Um, it So those are two things, right? We talked about the glutamate transporters and the dopaminergic, which is the descending analgesic pathway. Uh, what else also does? Okay, other thing it does. You remember the GABA? We say this is GABAergic neurons, right? Okay, some of them are pathogenic, some of them are GABAergic. Okay, and we know that the dopamine, the receptors are here too, and they stimulate those receptors to activate the GABA neurons, by the way. Okay, and so it's part of a descending analgesic pathway. Um, These GABAergic neurons release GABA, right? And that causes the numbing because they open up the chlor channel. Okay, what will happen if I said that nicotine receptor agonists partially can increase the expression or can the production of gabapentin? That's a good thing. If I can increase the gabapentin activities, this neuron, which is part of the sending analgesic pathway, I can put more inhibition over the pain signal. And nicotine receptor agonist, partially agonist, which is veroniclin, veroniclin, this drug or cytosine derivatives will help to increase the GABA synthesis. So it increase the dopaminergic, which is the sending analgesic pathway activities, the GABAergic, right? And also it increases the expression of glutamate transporter. That is the new insight of pain, of managing central pain, is in addition to everything that we have here, and we can add oxytocin, and we can add mushroom. Mushroom works by increasing oxytocin. Oxytocin works by increasing the activity of the descending analgesic pathway, by the way, because they increase all the happy molecules, serotonin and dopamine, oxytocin. And oxytocin itself increases expression of antioxidant as well. So it's good for central pain. But mushroom increases oxytocin and dopamine and serotonin, right? So mushroom increases the happy molecules. We call them the psychedelic, right? Those psychedelic increase the heavy molecule, so they increase the activity of the sending analgesic pathway. So in addition to all of this, and add to it the nicotine receptor agonist, which we can form in form of intranasal, and I need everybody to start consider that in managing central pain to spray nicotine receptor agonist in the nose, which we can compound it and make it as well. Um, so from what is the problem with the big pharma versus the natural product we talked about, the B12, the psychedelic, the oxytocin, all those natural things, the CBD, all of those natural things, they don't interfere with mitochondria. I mean, you can use methylene blue also as an antioxidant, anti-inflammatory. They don't interfere with mitochondria. But the big pharma product, the cyclic antidepressant, the ketamine, the serotonin uptake of the opioid, chronic use of those ones, including non-steroid inflammatory and steroids and non-steroid anti-inflammatory drugs, all of these big pharma products can cause interfering with the mitochondria. And anything interfering with mitochondria can lead to what? Can lead to oxidative stress. Because mitochondria is responsible to keep the oxidative stress in balance. And if you cause any dysfunction in mitochondria by correct use of those big pharma, why? Because their metabolites are not mitochondria friendly. So long-term use, you end up with mitochondrial dysfunction, lead to oxidative stress, and if you end up with oxidative stress, causing all the problems again, because the neuroplastic changes, progressive one, and the nociceptive neurons, and regressive neuroplastic and descending aggressive. So you're not doing that much there. That's the reason. Try to replace those big pharma products with more naturally, biologically friendly, mitochondria friendly drugs as much as you can. Okay, what are the things you can do? Can I improve the mitochondrial function? Yes. Give them light therapy. Light therapy helps. And we have the fiber optic ones that deliver into the spinal cord if you want, along when you're injecting your drugs with the steroids or like a steroid that you can use oxytocin, PRP, whatever, and then you can also try red light. And red light helps to improve the mitochondrial function, help to buffer the redox, and because it empowers the antioxidant capacity of the patient, and all of this helps decrease inflammation, oxidative stress, and normalize the neuroplasticity of the spinal cord. And we can do the same thing to the amygdala. I think we're good tonight. Maybe next Monday we will continue talking about how we manage drug addiction, because an extension of central pain is drug addiction. Because drug addiction must happen with central pain being mismanaged by opioid only, without comprehensive treatment of pain. The patient may end up with drug addiction with opioids and all those drugs. And we can really, if we have a comprehensive management of central pain that include cognitive therapy, that include all this nutraceutical, that include health optimization, that include um, empowering your spinal cord antioxidant capacity. It's very important. That includes neutralizing the free radical, including detoxing, including normalizing your metabolism, normalizing your redox, the things that we talked about, the pillars of the four pillars of chronic disease prevention management, normalizing the health of the patient in general, um, weight loss. All of this may help in treating those central pain more effectively than the way that we're doing currently, which is relying on narcotics and all these big pharma products. So I think we're good. Anybody has questions?
Yeah,
All
I
right.
had a question.
Yes.
I wrote it in the chat when you were saying that the women have more resilience to pain. Do you have any theories as to why that be? Perhaps
I think
progesterone?
because of the oxytocin during pregnancy, the oxytocin and the sex hormones, all of this are very powerful analgesics, especially the oxytocin. It does give them that resilience of pain during pregnancy and delivery as well.
But besides that, perhaps progesterone? Because oxytocin is transient
Yes,
only in
and progesterone, but we have also men, we have progesterone too, and they have progesterone. Yes, part of it. But oxytocin during pregnancy and during nursing, during all that, during delivery, it's high, and that gives them that resilience that the men they don't have. But really, in time of war, in time of thing, you will see the men tolerance is more, and because of testosterone and
yeah,
oxytocin as well. Right,
oxytocin.
right.
But how do we use progesterone for pain management here? I mean,
Yeah, intranasal, as you said, it just turns into GABA-like structure that will help in numbing the pain as you see it here. It's very part of the management. Um, I like to normalize the sex hormone for patient with pain. It's part of the pain management. If you don't do that, you're missing. I
yeah,
think so.
it makes sense. So for the central pain management, the intranasal progesterone, intranasal oxytocin.
Right. And sex hormone normalizing it and optimizing the metabolism in general. And some regenerative therapy as well if you want oxytocin, things like that, and B12 and psychedelic and ketamine if you the short term. All of this will help in managing central pain, not just opioids. Opioids by
Yeah.
itself proven to be worse the pain because you end up with drug addiction. And we're going to learn that in the coming slide because they lead to oxidative stress.
Ah,
Right.
good.
Okay, is that good? I think we got deep inside the mechanism and now we understood why we're doing all those things. When you understand the pathophysiology, it makes sense, the management, and it gives you that more confidence and more vivid visual about the case or condition of the patient and why we're doing the sympathetic block. And you just make it reason everything we do, and then you can create your own protocols and you can have better feeling about the patient's condition. Hi. Any other questions?
Dr.
Uh,
Halasa?
yes.
So in the very beginning, you were talking about central pain generation, and I always considered that central pain sensitization came about because of peripheral pains that were chronic, unrelenting, and then people lost their adaptive capability. But you said that actually central pain could occur primarily on its own. Is that correct?
Central pain is because of abnormal neuroplasticity of the central neurons, central
Okay.
nociceptive neurons. And you see those dendrites is growing and hypertrophy that's happening in the spinal cord sensory area of the pain and also in the amygdala. And all of this, they fire spontaneously to the point when they are being inflamed and all this neurogliosis, they just fire without even external stimulus.
So
And it's like
for,
seizure.
what are examples of like acquired central neuron neurogliosis? I mean, would a subdural, would TBI, traumatic brain injury, do they create central pain syndromes?
Right, part of post-traumatic syndrome, yes. The injury and trauma they have, there's pain components of it. That pain will be aggravated, and with inflammation, they develop central pain. And continuum trauma memories is activating the pain, and then you end up with hypertrophy in the amygdala and abnormal neuroplasticity there, and along with the memory, along with the sympathetic, yes, you end up with, it's a combination of central pain and post-traumatic, yes. Plus any to have trauma and still have the pain in that area of the injury, that peripheral pain progress into central pain, even if there's no peripheral pain signal coming from the peripheral, but the central is active. And then when the central active and it starts moving to sympathetic, and sympathetic causing vasoconstrictions and all that, then you have both. You have central and peripheral, because the vasoconstriction inflammation caused by sympathetic overactivities, it's leading to activation of the peripheral pain, right? Because that's how they're carrying the signal of pain, because you have inflammation there caused by the compositional pain syndrome. So you have both central and peripheral pain. You need to manage both. You need to restore the neuroplasticity of the central pain, plus you need to neutralize the whatever inflammation and whatever sympathetic activities that is causing the inflammation.
So, I mean, there's a lot of ways that we can traumatize the central nervous system. As you said, memory can, but pre-memory, I mean, sexual trauma is certainly probably a higher risk factor than traumatic brain injury or central pain. Would you agree with that?
Yeah, especially if the sexual violence and the memory and the stress itself, and the trauma of the pain, the thing, it can activate whatever pain they experience during the sex, if there's any pain. Most of the sexual trauma, they will have some pain as well. So it will add together.
And we have you know, situations of people like veterans that suffered enormous time in combat zones, but then they were able to somehow transcend that degree of acuity and longevity of trauma, become highly resilient personalities, and others that have minor, you know, TBI that really suffer tremendously. So where does the risk factor come? What part of the brain is it all amygdala? Is it prefrontal cortex? Do we know anything?
You mean the variation between people who are continuing having post-traumatic syndrome and patients who in the war and their resilience and they don't have the post-traumatic syndrome? There is genetic variation, part of it.
Is there what are the variants? What do we know about risk factors of who's going to be resilient or who's not going to be resilient? And can we enhance the resiliency of someone who's already been through those experiences?
Right, you know, but with cognitive therapy that we're doing, with the treatments that we're doing, is to restore those neuroplasticity back to normal. It's a combination of cognitive plus pharmaceutical or nutraceutical and health optimization. We can help in managing those post-traumatic patients syndrome. But is there any genetic variations in people who have more prone to post-traumatic versus others? Yes, there are genetic variations in pain tolerance. It's all genetic variations, and it's all about the culture and belief and faith, and it's a lot of social, cultural, cognitive involved as well. How the person being, grow, and also their belief in faith, can also affect, as we know, the cognitive function of the brain has tremendous control over the pain signaling, by the way. And very powerful inhibition if we train the cognitive. So it's all about cognitive therapy as well, in addition to some pharmaceutical, just to put that fire down while we are processing or training the cognitive function to do the work.
I found your stepwise progression from thalamus to amygdala to hypothalamus to the primary somatosensory cortex and then the sensory association cortex and the behavioralisms that we see clinically in the expression of the suffering to pain, because we know that suffering and pain are distinct entities, right? And in between there is that resiliency. And I've had conversations with Richard Niemtoft, who's the inventor of battlefield acupuncture. And that's been a breakthrough for the vets suffering from PTSD and from central sensitization, and also these other peripheral expressions or central expressions of peripheral pain, like phantom limb. And it involves just semi-permanent needles put into the auricle along the cranial nerves. And there's a homuncular description of where those needles are going that's been mapped out by functional MRI. And it's primarily, he has his original battlefield acupuncture, and then he has his advanced battlefield acupuncture for people that are refractory to the initial treatment. And the advanced treatment, it's all going from the hypothalamus to the cingulate gyrus and the insula. And I don't know much about these midbrain structures and what their central functions are. And but it's fascinating to, I use it a lot, and it's quite effective. And the patients will typically come in and say, well, since you've been putting these needles in my ears that last about 3 weeks, I see the patients on 3 to 4 week cycles. They say, well, I still have my pain, but I'm so much more active and it doesn't bother my sleep and it doesn't bother my daily activities. I still have pain, but their functional resiliency is markedly improved. And most of these are people that have failed pharmacology and CBT and other things. Some of them get benefit from some of the sympathetic blocks that you were talking about, like the stellate blocks, but this is so much easier and so much less expensive. And it's gone from the VA to Kaiser Pediatric Emergency Medicine, and it's really making a nice progression throughout the big systems out there, and very easy to learn.
Yeah, I think all these acupuncture therapies, they help in increasing the parasympathetic. They help in, which is anti-inflammatory arm of the sympathetic of the autonomic nervous system. They help in possibly directly in the brain, empowering the enkephalin and GABA and all this, interrupt this pain signaling, maybe changing the neurotransmitters of the brain activities as well, and putting the inflammation down through those acupuncture therapy, along with so it does help in changing and modulation the neurotransmitters activities, and possibly breaking those neuroplastic changes that's happening in nociceptive neurons, and also empowering the antioxidants activities as well. And all of this will help to rewire the brain back to normal. So I am with acupuncture. I think acupuncture it's part of changing the activities of the brain and also activities of the autonomic nervous system, especially increasing the parasympathetic, which has anti-inflammatory arm, and normalizing the neuroplasticity of the brain. And that's the goal of doing all of these things. And if you experience by clinical that you have patients treated by acupuncture, I think along with that, there must be cognitive therapy, and it's good to do also some pharmacology there as well, and health optimization. As a combination, all of this may help to restore the neuroplastic changes of the brain and fade out all this extra synapses and connection that's abnormal ones that leads to this vicious circle of memories, abnormal memories or bad memories and extra sensitivity of pain.
If I may say one thing, because you've mentioned acupuncture, battlefield acupuncture, other acupuncture, and also have mentioned the peripheral stimulation of the central nervous system. And the Germans have described all this for the last 70 years, that you can't do acupuncture unless you do the neural therapy or block, or rather open scarred areas, traumatized areas, or areas that would be considered interference field. So however you define interference field, it can be normalized by injections of lidocaine. And so to reduce the central stimulation and sensitization, you need neural therapy. You mentioned phantom pain, you need neural therapy. So you have to avoid the abnormal stimulation, or what the Germans called interference field in these areas. So once again, both areas, you need to have neural therapy to open up the meridians, and then you can balance them, and then that stops the sensitization. But that's a big,
I like
That's a-
multi-therapy. So all those therapies that you talked about, the aim and the goal is to restore the neuroplastic changes of the nociceptive neuron back to normal, and also the descending analgesic pathway, and all the memories, that those bad memories, is to fade them out because they're all abnormal wiring and too much sensitized. And antioxidants effect of the acupuncture of the and also the interrupting of the signal of the pain as much as you can with the with your methodology. I think neuronal therapy, all of this will help to optimize the neuroplasticity of the brain back to normal. That's the aim and the goal, and that cannot be done only by interrupting or numbing the pain signaling or the synapses of the pain by opioids only, or by ketamine, or by it needs to be involved cognitive therapy, health optimization, sex hormone optimization, detoxing the body, weight loss, all of this, neural therapy, as you said, acupuncture, all of this will help collectively to reach the goal more effectively, more efficiently.
yep.
Right.
Thank you.
Good. Any questions? Everybody's happy? I'm sorry for the holiday. Some people, they want to enjoy the holiday and stay at home and with family. But again, there's some nerd doctors like you who enjoy hearing those, signs and hard-headed things, hardcore things. So it's all, as I said, dopamine driven. And some of you being polite just to be nice and staying here just to stay, in other words, filling up the company. And so I appreciate that too. Good.
Thank you so
Yeah.
very much.
Okay,
Yeah.
we'll be in touch maybe next Monday or tomorrow with Dr. William. There's a very nice lecture for cyclodextrin, so I encourage you to attend it. Okay.
Yeah.
Good night, everybody.
How do we get the code for CMEs?
I did put it in the text there, but I'll put it again. Let me see here. Copy the link. And then here we go. And you got it, right?
So if we click on that link,
Click on that
and
link.
it says continue to enduring medical.
Yes.
And is it?
You see it?
login-
And then you just continue, and then it gives you your information.
And then it asks me to pay.
Right, $30 or whatever goes to that organization.
Doesn't go to you?
No, directly. No.
Okay.
Is it
Doesn't
good?
go to- Okay, thank you.
Okay, we'll see you then.
All right. Good
Good
to see you
night.
again.
All right,
Bye-bye.
take care. Nice to see you then. Bye.